A short bit on tinnitus. Sometimes it can be related to your neck. Just put a pin in that for. We won't do a tinnitus talk, but the nerves are anyway crossover and all this stuff. Okay, so sources of knee pain. The knee pain is the hinge joint, so it's mostly doing this, but it's got a little bit of give, a little bit of twist and side to side. You've got a big muscle coming in the top that crosses this patella and then attaches here. So this is kind of like a pulley, you know, almost like a pulley system. This bone creates more torque across the knee by kind of jutting the, you know, making it go like that before it attaches. Ligaments on the side, and then hamstring in the back. I mean, there's a few other things in there, but so it mostly does this, and where we get into what I find is where most people, let's say you're just having more musculoskeletal knee pain, has to do with the way these two bones are interfacing with each other. So if they don't have a nice straight line, if you look down and like the bottom bone kind of looks a little shifted over, or if you start noticing that one bone is kind of twisted that way and the other one is twisted that way, or you have a lot of force this way. Anytime the knee, it looks like it's starting from a position that's not in this plane, that you're getting this kind of movement or movement like this, then that can start to create wear and tear and inflammation and all the things that kind of get labeled as itises, like a bursitis, which is swelling in the bursa, a tendinitis, which is inflammation around the tendon or attachment from the muscle to the bone. It can cause ligamentous strain and swelling around that, stress on the muscle, and then also, you know, over time that can lead to small degenerative changes, which is sometimes how arthritis gets started. Little micro traumas and stress, and there are other things with arthritis in terms of inflammation through your whole body, different things that might be creating inflammation in general that then worsen one area where you have a little more of a struggle. So with arthritis, you know, you've got inflammation and also sometimes less space is what's characterized in the joint. So there's not as much space between the two joint surfaces, and then you're starting to get inflammation and some wear and tear on the things that cushion the joint and lubricate it. So
what cushions the joint?
Inside the joint you've got meniscus and also cartilage. So it's like connective tissue that's thicker and helps the two bones slide against each other and create some, you know, compression within the joint. So with arthritis, one of the things that can help is trying to basically create more space so that you get less compression on that tissue that maybe has already had some degenerative changes to it, but we want to, which, you know, we may not be able to reverse that, but we can introduce more space into the joint so that you're not getting so much of that compression, and also improve the alignment so we're decreasing the inflammation that's coming into the joint because of just wear and tear versus more of a systemic kind of inflammatory response. So one big thing that sometimes people have questions about is also meniscus, like, well, do I have a meniscus tear or do I have a ligamentous strain? And those are things that there are a lot of orthopedic tests for that we can figure out. With meniscuses, sometimes they can be tricky. There is potential for them to heal. It depends a little bit on maybe how big of a lesion, so to speak, is in that meniscus or cushion in the knee. They did in a study where they looked at people 5 years out, people who had meniscus knee pain, and then 5 years out, people had surgery and people didn't have surgery, and their, you know, function, quality of life was not significantly different in those two groups, people who had the surgery or not surgery. Now, you know, what was your quality of life for that, you know, year right after you had the meniscus? So it's not to say that sometimes surgery isn't indicated. It definitely is. I just had a patient who, she had a really big flap, and we could get it smoothed out through manual techniques and aligning her knee better so that the meniscus wasn't getting twisted and irritated where the problem was. It had happened after a fall for her. But as soon as a funky force came through the knee that was unexpected, that little lesion would kind of wrinkle up or kind of change its position instead of being smoothed out. And so in the end, she went ahead and, you know, opted for the surgery.
You were just providing a temporary fix. It wouldn't last.
In her case, it wouldn't last. And when the surgeon got in there, it was like, oh, that was a really big, you know, flap or kind of tear. But a lot of times it can be helped. And you don't necessarily have to. Well, let's talk about this. Let's go from there into a little bit of different things that can help. Do you have any other questions about just like names of things, patella tendonitis or chondromalacia or anything like that? Or those?
What was that last thing?
Chondromalacia is one that gets named for there's cartilage underneath the kneecap, and sometimes that cartilage can get kind of worn, and then they call that.
Is that what they talk about with older adults? They say, oh, well, there's no cartilage left.
That's kind of what they're talking about. It's a
bone on bone, that's what you hear.
Yes, I know. Okay, I'm glad you brought that up, because we're learning a lot. We used to think when we took images, x-rays or MRI, and we saw something on the images, it was like, oh, see, that's where you have your pain. Go have the discectomy, get the knee replacement, whatever it is. And then they started kind of looking at, well, what do these images look like in people without pain? So let's look at people, MRIs of backs of people without back pain. And they look a whole lot like the backs of people with back pain. They have bulging discs, they have degenerative changes, and the same thing with knees sometimes. So the image is not everything, or the diagnosis is not everything, you know, so bone on bone. Okay, well, we all have, you know, we all have bones interfacing with each other. Sometimes you get over a hump where that really is maybe the best solution, but not always. So for instance, in this situation where I was seeing the woman who had fallen, she had the meniscus tear. The first image that she got, the doctor said, oh wow, you have a lot of arthritis. I'm not even really worried about your meniscus, you have a lot of arthritis and you may be headed for a knee replacement. Well, she had no pain in her knee, was hiking, was doing everything she wanted until the fall and the meniscus injury. So you kind of go, well, the arthritis was there before and you were fine. The only reason you know it's there is because you had this image. So it's just a lot to kind of consider and keep in mind that that doesn't always tell the whole story. It may eventually be the biggest part of the story, but especially early on, you know, there may still be, so we've got kind of like disease processes, and we've got the way that your knee and leg are functioning. And so it can be a little bit tough to tease out, are you experiencing pain with activity because of this, or because this is so advanced, or is it some combination? So there's sometimes limitations to what we can do conservatively to like degenerative disease processes, if you want to call it. You don't even want to call it disease. Some of this is just normal aging. It's just normal changes. Everyone's going through them. And then how you're functioning. So if you work on all of this, how you're functioning, and it's kind of like you're still struggling, then maybe this is a bigger piece. But if you haven't sort of worked on this, it can be hard to know which it is. And So that was a little bit about how the limitations of images. It's still really cool that we can look inside our body. So x-rays are going to show you things like bony changes. So it'll show arthritis in the sense that if you've had increased bone growth because of increased pressure, bone responds to force, and so the more force that you have through the bone, the more bone is going to be laid down in that area. Remember when back in the day when we were kids, we wrote with pencils? We don't do that anymore. And you get that, you get that little lump. So that's constant pressure on the bone, and it sort of thickens up a little bit. Same thing with the bunion happens, and then the same thing for most people happens on this inside edge of the knee for some people, and then that's what creates some of the narrowing. That's why you're supposed to do strength training when you move into osteoporosis type ages, because the bone responds to that stress. It's a good thing that the bone responds to that stress, but sometimes if you have too much stress on one area of the bone, then that's where you start getting into things like bone on bone, osteophytes, you know, degenerative bony changes. Those are kind of like the words that start coming at you from these types of images. So x-rays are going to show more bone. And so they'll tell you something about arthritis, fractures, big things like that. MRIs and even CT scans are going to show more soft tissue. So it's going to show you the muscles, the blood vessels. It'll light up with certain areas if there's inflammation or fluid. So it's going to tell you more about ligaments, muscles, the meniscus, the cartilage on the layers of the bone, in the back, the disc, if you have pressure on nerves. So it's telling you kind of more than the x-ray, and it's sort of like a hierarchy in terms of how much information you need and how much the tests cost in terms of how they start. The doctor starts ordering them. So those can be useful for ruling out big problems early on. If you have something like you fell and you're worried you might have a fracture, if you have neurological changes and you want to make sure there's not something else more insidious than just kind of normal wear and tear and aging going on in some part of your body. But in terms of just pain, having pain, they may not always be the best place to start, because if you go looking inside, they're probably going to find a little something there. But that may not be, you know, and then you kind of get in your head, well, now I'm screwed. Because I got, you know, what am I supposed to do about that? I can't change what the inside of my knee looks like. So physicians, I think, are a great place to start to get referrals. If you're needing like some kind of medicine, like anti-inflammatories, because you just need something to help calm you down earlier on, and that kind of thing. And then I'm a physical therapist, so I'm biased. Physical therapy is going to look at how's your body working, do you have strength imbalances, do you need flexibility changes, and do some of that to help the area work better in spite of whatever's going on. And then there's also, you know, there's chiropractic, there's acupuncture. Those can be helpful for adjusting, you know, joints, pain responses, and that kind of thing. Who else? Anybody else that you're like, should I go see a massage therapy?
Oh, did you say chiropractor? You said chiropractor. What am I thinking of? Podiatrist.
Podiatrist. Yeah. 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 So the foot is interesting, and it can also affect the knee. So the joints directly above and below the joint where you're having a problem can often be areas where maybe you're not having the pain, but that's where the thing is, that's the thing behind the pain, the reason that the knee isn't working as well. And so the foot is an area that we can actually get a lot of changes in the shape of the foot, in the way the foot is underneath your body and working for you. And I think podiatrists are great. I think sometimes I feel like the approach for some people is to look for like, well, let's put something in your shoe to help the way that your foot is working and interfacing with the ground, and that can definitely be a great solution. I like to kind of work with the foot first and see how functional can we get your foot on its own first, and then if you still need some support, adding some support in, because we can actually get some changes in the shape of the foot as well. Yeah.
What do you think about those injections that I've been hearing about as an alternative to knee surgery?
Okay, yeah, like there are a bunch of different injections, and I know just the tiniest bit about them. Hyaluronic acid is one that tends to be covered by insurance, I think, because there's some research on that it does well in the knee. I can't speak to a lot more about what it does. And then there are more alternative injections that sometimes like an osteopath or someone who's working outside of the insurance model might do. It tends to be like platelet-rich plasma is the name for that. There are different things. And I think those can definitely be options if you're... I would always advocate for try to get whatever the thing is that hurts, see if you can get it to work. See if you can manage the inflammation as conservatively as possible. And then you're kind of always working that like, well, this is kind of working, but I've only gotten 70% from this, so if I added this other layer in, then maybe that would take me the rest of the way, you know. So I think those are definitely options. Some of them, yeah, for sure, yeah. What else? Anything else with like different people in the medical model or different things that you've heard about for?
You kind of mentioned hormonal changes as we age.
Yeah.
Like, you know, osteoporosis or whatever. Are there things you can do, like supplements or foods or anything nutritionally wise that, I don't know if that's probably maybe outside of the scope of this, but, you know, managing some of that inflammation based on nutrition or supplements or something?
Yeah, that's a really good question. Yes, diet is the kitchen is a great place to start trying to battle inflammation if it's something that you have. And that can look really different for a lot of different people. You know, what's an anti-inflammatory diet? What is it like for one person? What's it like for another person? So you can definitely go down some roads of, you know, how, you know, starting with just generally like whole foods, not processed foods, limited sugar, getting fiber, those types of things. And then sometimes people have even more, like they're sensitive to dairy, you know, dairy, gluten, corn, or soy maybe, or some of the big ones where if you're just feeling like that's a big piece of it as some inflammation that's not really making sense, then working with someone to help figure out, do I do an elimination diet? What am I going to start with eliminating? How do I, you know, giving it time to see how you feel. You know, in terms of supplements, there's a lot of chondroitin, glucosamine and chondroitin sulfate are some that I haven't looked at the research lately. You know, it's like, that might help, you know?
Yeah, she'd taken it for a long time and then it was like, I didn't notice any difference after
So,
stopped
yeah.
taking it. You know, it's like...
experimented with a lot of different things and I couldn't really say if anything works or doesn't work.
MSM and chondroitin or glucosamine and combinations.
Yeah, I think it might be kind of an individual thing because I've known people who it works for. So I've seen some studies that say that you know that they don't work. Those no studies that they don't show any. But then I don't really. But anecdotally, why are so many people seeming to benefit from them? There's people. So it's like it makes me think.
Well, that could be it.
Yeah, I mean it's like what's going on there? Right?
Yeah, well, it just makes me think maybe it's like everything. There's an individual variation.
I think that's possible, for sure. Yeah, and the research is a little bit like, it's not really no, but it's a little like, you know, maybe. So then it's worth trying, I think. And then if you're not seeing big changes, then, you know, I'm not sure it's worth
It doesn't work for you.
Yeah, continuing to invest in. I think, you know, another big one right now is CBD. It works awesome for some people. CBD, the
Yeah, right. That's a big one I hear about for knee pain. people, they say they swear by it.
Yeah, but for some people, it's just
topical or oral doesn't seem. I guess it could be either or, right?
Could be either.
Yeah.
Yeah. So there are some endocannabinoid pathways in terms of your pain pathways, but I think that can be very individual too in terms of how does that pathway work in you, and is it very effective? Yes, and so steroid injections, that's another one that a lot of times comes up. So those can be really powerful. They can be helpful in terms of diagnostics. They can help you get out of pain. They're not going to address the underlying issue unless the main underlying issue was you just way overdid it and you can't get this thing to calm down. And sometimes you get the injection and you move on with your life. But a lot of times for people, it's a little bit of both. And so I think always kind of just figuring out what am I using as a tool and how am I using that as a tool to solve my problem versus, thinking, well, maybe if I just get an injection, this will go away. Because sometimes that doesn't always work out, or it goes away for a while and then the problem comes back, and those types of things.
Side effects, right?
There are side effects. Typically,
cortisone injections or whatever those are.
Yeah, they'll only give you so many because they can start to be degenerative for the joint. So I think they have their place, and again, it's really individual in like how your course is going, whether it just makes sense to do that. Yeah.
So I have a question about inflammation. I mean, we talk a lot about getting rid of the inflammation, but the inflammation is your body's way of creating a cushion, right? So, inflammation for me can be painful and it limits my mobility. But sometimes when the inflammation is gone, then I have.
I locked the front door.
Oh,
It's easy to unlock, but I didn't keep the dogs out.
okay. All right, thank you.
When the inflammation's not there, then it feels like my knee is more vulnerable and will catch or will lock. So it's kind of like you're damned if you do and you're damned if you don't.
Yes. Yeah, that's a good point. And there's a lot out right now, like, well, should we be icing things? Do we need to let the inflammation run its course? That's your body of trying to bring nutrients to the area and heal it. And so, I think sometimes there are differences between something acutely happening and the swelling and the process that has to go through, and then something a little more chronic where it's just kind of always there. And so how much is that helping? It sounds like if you've got something where the swelling makes it feel more stable, then yes, it's a little bit. I think a couple things can be going on. One, when you do have sort of like sharp pain, it's very inhibiting to the quad muscle. So the pain sort of signals to the brain like, don't tighten up because you're gonna pinch something or make something hurt. And that's sometimes that feeling of like pain, and then you almost feel like it might just go out from under you. And then there could be some issues of just stability in terms of either if you've had injuries or that your body just isn't quite sure how to manage the area. One thing that happens when you've had pain for a long time is we have a map of our body on our brain. It's called the homunculus, and sensitive areas are bigger and less sensitive. Pinky toes, sometimes not even on there because we're in a shoe all the time. Lips and fingertips are very large. So when you have an area that's experienced pain, the representation of it on your brain gets hazier or kind of smudged. And so the brain starts kind of, it doesn't understand and have quite as a solid of a connection with the area the longer that goes on. And so that can lead to, decreased coordination, a decreased sense of kind of balance or confidence in that area. And then if you're having pain and you're kind of always unloading that side, like sort of favoring it, then you slowly get a little bit of weakness because those muscles aren't getting used as much. And so that may be part of the pathway to feeling like, oh, it just doesn't feel very secure. even if the inflammation is down, the knee feels like it's not solid. Yeah, does that help with that?
Maybe it also sort of explains why sometimes, you know, when we've gone out for a longer walk, there was a walk we did recently, because we ended up being about 8 miles, so it was longer than we'd expected, and I just had pain everywhere, but I couldn't really pinpoint it. You know, I mean, I knew my knees hurt, but my legs, my feet, my hips, it was just kind of like this general pain all over, and it was sort of odd that I couldn't say, well, it hurts here or it hurts here. It just was a very general discomfort, maybe that what you just explained.
Yeah, and I think the other thing that can be playing a part in this is the back, your back as well, with long walks. So depending on your, you know, the position of your back, how strong the core is around the back, and especially if you're doing up and down, where maybe you're kind of leaning, or, you know, and you start to get more fatigued, then the back sometimes is also experiencing a lot of the same compressive forces and fatigue that the legs are. And when that happens in the low back, we, because the nerves to our legs come out there, it's not that you're getting like a pinched nerve per se. It's more that you may be getting sort of weakness, fatigue, inflammation in and around those nerves, and we can end up having a feeling of sort of diffuse. I feel like when it happens for me, it's like a diffuse kind of achy, gnawing, kind of just from there down.
Like the nerves are overloaded, and so it's just kind of general.
Yeah, and it's not frank pressure like numbness, tingling, weakness. Those are like, that's like very specific compression on a nerve that's happening. But you can have, it's called spondylogenic pain, and so it's pain that's mediated from, it's coming from those spinal levels. There's nothing frankly wrong, they're just not happy, kind of like your knees not happy. And so but you feel that discomfort along the pathways of the nerves that they would go to. It's hard for your brain to differentiate. It gets these messages from the areas of those nerves that, hey, we're really looking tired, we need to lay down and take a rest, we've got inflammation, everything's sore. And so it doesn't know, was this from the back, is this a leg, where's it coming from? When that happens, sometimes heat, you could experiment with this. Heat on the back sometimes will ease that aching.
We got into a cold waterfall, like, you know, went out, got into a cold waterfall, and so that might have been counterproductive.
Well, you know, this is the age. Do the one that works well. It probably did help with inflammation in all of your muscles. The nerves sometimes like the heat, so it's, you know, you can kind of play with it and see which one feels better. Okay, so let's do a little bit about just how the knee works, especially with, I'll go over a few things that I tend to look at, and then that'll lead into a couple of simple exercises, and then we'll see if we can get a couple of those knee hacks in for you. Okay. All right, so I almost wore shorts today, but I didn't want to wear shorts for this reason. But, so we talked a little bit about the knee being a hinging joint. So when we're looking at the knee, we're really looking at, you know, how does it do this motion? We expect there to be little rotations, but if what's happening as you bend is you're getting a lot of here and then here, this type of movement, or what I often see in people is this bone will be kind of internally rotated, this one be externally rotated like this, and then when you straighten up, that they're starting, it's like they're looking in different directions. So you're getting kind of this wringing out of the knee there.
What causes that?
It's time, and sometimes it's like the shape of your bones, the way you've developed, but also there's this concept called tensegrity, and we have the fascial system, which is connective tissue. It's all throughout your body. It's like a web everywhere. It's over the muscles, it's in between the muscles, it's around the organs. It's all over and underneath your skin. If we took all your cells away and you just had the fascia left, it would look like you. It would still, we'd still kind of see who you were. There's so much in there. So that webbing, like sometimes we think about muscles as like, it's just like pulleys, but sometimes it's helpful to think about this tensegrity model almost more like you're jello and the bones are kind of floating in this web or matrix of muscle and fascia. And so it's like things can, for lack of a better way of talking about it, get sort of smushed. So it's like the jello's kind of like been molded in a way that's not as well aligned. But so here, sometimes that's tightness in the adductor. It could be tightness where this is the lateral retinaculum of the knee, where the IT band comes across, so maybe this joint is compressed and it's gapping this side, and so all kinds of things, the hip, the ankle. If you've got a foot that tends to be flatter and kind of doing this, then you've got a bias towards the hip rolling in, and that's where a lot of times that inside edge of the knee pain and bursitis comes in.
Bad
yes. Yeah. Yeah.
How do you think you got your knee problem?
That's what I'm hoping to find out. But I mean, that was a question about, because, you know, I've had that since I was a kid.
Yeah.
Has that problem, you know, is that causing the knee pain, or you know, has it contributed to that over time, having those
right? I mean, probably. To me, in the way that I kind of understand how the body works, I'd say it's probably contributing. And you know, if it's always been like that, you may not totally get it to be the other way. But if you can kind of a little bit plus a little bit of an arch support, and just start, you know, moving towards the center of a little more balance, and then you see how much change do we have to get below symptoms, because none of us are walking around like perfectly efficiently, perfectly symmetrical, right? But sometimes we go for a long time and we're asymptomatic, and then all of a sudden something happens where it's like, oh, now it hurts, and it feels like it came out of nowhere. I used to be able to do this, now I can't do this. And sometimes we've had these changes and they're slowly coming on, but it's good enough. And then one day it's sort of like, it's not good enough anymore. And so then we're figuring out how many layers in all these different places can we peel back to get it good enough again, basically.
Right, and especially as you get older, you're losing muscle mass.
You're losing muscle mass.
So you don't have the support system that you had maybe when you were younger.
Yeah, yeah. And that's, that's one of the big things with aging, is that muscular atrophy over time, and how to combat that with, which needs strength training.
Right.
That's right. Okay, so that's a little bit about that, and then we can look at how what happens when we stand up on the knee, coming up, and then especially coming down is where a lot of people end up having trouble. And I'll see if I can demonstrate a little bit. So let's say you have a really stiff ankle that only bends, so for instance, this one is really stiff. So when I step forward, I can only go down so far before my heel has to come up, because my ankle just it'll just only bend so far. Compared to, this one is not amazing, but it's better, where I can go lower, 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 lower before I have to come forward. I can go like that. Here, I have to go a little more like that.
Is that why they say walking downhill is sometimes harder than walking uphill?
Yes, that's one of the reasons. You're also walking downhill, so you're getting more like this. The femur is coming driving this way, so a lot of times front of the knee pain is much worse going downhill. The other thing with going downhill is the ground is pushing back at you. You know how it's like you don't want to fall down the hill, so you're going down the hill and you're also sort of stopping.
Right, there's resistance.
Yeah.
Catching yourself.
Yeah. And
it's where like maybe poles or something.
Yeah, poles can be helpful.
To offset. You
Exactly.
don't have 2 points of contact. You've got more to.
Exactly. Yeah, and balance you. And sometimes smaller steps as well. So it's a little more like you're kind of rolling down the hill instead of a long step and then stopping. A long step and stopping. So you're kind of those things can help. But that's just one area where the ankle can affect the knee. But let's look at, especially because some of the exercises I'm going to show you, I haven't talked a lot about the hip, but the hip is an area where we can gain a lot of improvement to help with the knee. And that's because the hip is going to kind of control this type of movement and help keep the knee able to mostly function in this plane instead of bending and twisting as it bends and strains.
So it's more mind.
Exactly. So as we come down, lowering, sometimes what we'll see is the hip starting to do this and this, so we've got this kind of angles here. And it's hip strength that's going to help you keep it more like this. So able to keep the hip, knee, and ankle all aligned when you're going downhill, or also just landing with your foot on the ground. If you don't have a lot of strength here, then you're going to be kind of collapsing through here, and then you don't have as much stability at the knee. So let's talk a little bit about how to does that work?
About what? Strengthening.
Strengthening your hip. I put all this stuff up here. I don't know why I did that. So I like to start with, ooh, you guys want to feel these? These are nice if you do want, I'll save it. I won't distract you. Remember Jane Fonda?
Yeah.
So,
She's had 2 hip replacements.
is that right?
All those aerobics.
I know. Maybe all the men in her life. I don't know. She got worn out. Sorry, that's not. Okay. Yes, it's probably his fault. All right. So, hip strengthening. This is where you want the hip strengthening to come from, because this is what helps keep the hip level this way and the rotation. So I usually have people start with side-lying hip raises, and where this tends to go wrong sometimes is this is really tiring right there, just to lift the weight of the leg. And so what happens is most people want to make it easier, because no one wants to do anything hard if they don't have to, including me. So people tend to roll back a little bit, let the toe rotate a little bit, and now we're using this muscle that tends to already be really strong. And
It makes it easier because the quad's stronger. Okay.
Exactly.
Interesting.
Yeah.
Huh.
Yeah. So
The other thing I wondered is, I haven't tried that exercise. I wasn't clear where my leg, was the leg supposed to be out in front? Like,
yeah, so you can do it different ways. If you've ever done Pilates, they'll have you put your leg out here, do this leg series like that. So it's not that there's a right or a wrong necessarily, but when I'm working with people who are walking, hiking, running, I like to work with it in as much of a neutral hip extension position as we can, since it's, I mean, in some ways you could argue where you land, but I think you get into the external rotators better when it's straight in line. So it almost feels like it's behind you. When you look down, you'll see your toes versus here. But there could be there's different reasons why you might put it in a different position, and you can do both. both, but this is usually one I start people with, and working up to 30 of these where you're just abducting and then keeping it there and internally and externally rotating it.
I don't get what you mean by abducting, where you're just abducting.
Yeah, ab means the leg is moving away from you. Adducting means it's going this way. So you're just lifting it up. Yeah, there, and then doing this little back here. I mean, mine's already burning. So working up to being able to do 30, 30, 30, but those on each side before we progress to doing standing, more dynamic things.
How long does it take to get, I remember, how long do you have to do that exercise to make benefit?
To get strength. Yeah. I mean, every time you're doing it, you're getting benefit, but in terms of hypertrophying a muscle, which means we're actually making more of the muscle, we're creating more fibers in the muscle and bulking it up so that there's more muscle to be stronger, you're looking at like 6 weeks. But you're always gaining some, it's interesting when you start focusing on muscles, you're gonna see some strength gains just from working on the neuromuscular control and the coordination and the bringing your mind to that, you know, using the muscle itself. But if you just frank hypertrophy, the muscle got bigger than it used to be, there's more force output. You're looking at like 6 weeks of consistency, 3 times a week where you kind of fatigue the muscle. Yeah. Okay, so there's that one, and then I'm going to show you one other one that I like for hips because it works on hip extension, the glutes, and also a little bit of abduction. You can do this without the band, but it's nice with the band. Keep the distance apart, and you've probably done a bridge somewhere along the way, but you're doing a little press out. And then what I like people to do is, as they're doing this, to think about pushing your feet, to initiate the movement by pushing your feet into the table. And what that does is it initiates the movement with the butt muscle or the hip. Because sometimes what people think is, I need to lift my hips off of the table. And for a lot of us, our back has decided it should help us do things that our legs should be doing for us. And so we end up doing kind of like some of this. And you're getting like pinching in your back, and you're kind of arching, and the core isn't really engaged. So what you think about as your intention for doing the movement can help kind of drive the movement in the way that you want it to go. So pushing when I think I'm going to push my feet, my hips are automatically coming up, but they're coming up because my glutes are the muscle that has to do that work. And then I'm also, so a lot of nice things are happening here. You're working the glute, you're working external rotators. You're also basically getting a stretch through the front of your hip, which is where tightness in the hip is a lot of what changes hip alignment, and then that affects the knee. So it doesn't take a lot of these to get tired either when you're really focusing the movement into the butt joint.
And you're holding your legs out with that stretch band when you do it to give it some to work here. So you should feel some tension there.
Exactly. Okay, so those two are really nice ones to start with, and they're laying down, and I like all exercises that you can do laying down. Because at least you sort of feel like, at least I got to lay down. Once you're doing well with those, then I like people to start getting upright, but still fairly controlled, where we're working on accessing all those movements. This way, and this way, but standing on the leg. So if we have weakness, the opposite of that happens. We go that way, and that way, when we stand on the leg. And if we have strength that we're able to access, then we get all those motions which keep the leg stable. So if I'm kind of relaxed and not in my great posture, then if I go stand on the leg, it's still, I mean, my butt's not really, you know, your your body figures out how to do it without always kind of really being really stacked and engaged. So then you're starting to learn how to really be on the leg in an extended position where all the force and the weight of your trunk is going into the muscles of the leg and not hanging more passively through some kind of ligamentous tension, or the back is sagging and the weight of the trunk is just compressing the low back and things like that. So then that gets a little more nuanced because sometimes mobility is affecting that, all those things. But then that's the progression, is taking that into upright and being able to do it, and then being able to do it, you know, more dynamically off of a step. And what I think happens a lot of times is people look, maybe if they're looking for help or they're looking for exercises, they end up finding things that are too difficult. It's like, so this is
offer easy.
This is a great exercise for strengthening your hip, but not if you can't really do it well. Then you're just reinforcing how you kind of are already bad at stuff.
Well, and also if you have a lot of inflammation in that knee and your knee doesn't want to bend, then that kind of action is going to be difficult.
Yes. Yeah. So yes, that's exactly, I think, one of the things that happens too is people feel stuck. Well, I need to exercise so that I don't have so much pain. Every time I exercise, it hurts. And then you kind of get, you know, sort of stuck.
Yeah. It hurts.
So finding exercises, one, that don't hurt, and two, that are at the level that you need, so you're building a foundation. Sometimes people are throwing it's like the fun kind of sexier exercises are like, it's like the house and framing the window and the door and, you know, but you really need like the concrete cord first. If you want all those other things to be as effective to get the benefits from them. So it just kind of, I mean, I feel this all the time. It kind of hurts your feelings because you're like, really? Just, you know, you want me to do this? You want me to, you know, like, I did CrossFit. I did, you know, I'm tough. I'm good. And it's like, well, yeah, no, that's right. Sometimes we're finding small little muscles. This is another thing, is that even in the knee, especially in the back, but even in the knee, the muscles that stabilize get inhibited by pain. And so they don't always come back on. So you could have really strong, long muscles, but if you don't have some of those more stabilizing, smaller muscles working, then all these translatory things happen at the joint, and that causes irritation.
There is a feeling I get that there's a lot of little muscles around the knees.
Yes.
Aren't there? Because
there are. Yeah. Yeah.
Yeah. It's a nasty joint. All these things going on there.
Okay, I want to get to a couple of the knee hacks, and just so you know, as a little teaser. One is for some people, let's say I have pain bending, you can play with the position of this bone by either turning it out or turning it in. For most people, turning it in helps. So you kind of like, you move it and then you bend and you see, does it feel better? Like, did I get the pain to go away by changing the alignment? And then, if you did, then you could try to tape it in that position. Taping can also be nice for, sometimes for the kneecap for people. If you're getting pain like really just right around the kneecap, then taking, you know, seeing if I push it a little bit that way, does it feel any better? No, if I push it a little bit that way, does it feel any better? So you're just kind of playing with, can I do anything? Can I just jimmy something in my knee that makes it feel a little bit better? And sometimes just repeating that movement will at least decrease your pain. So maybe you were at a 8 out of 10, you could get it down to 6 out of 10, and at least that was something.
Have you tried that? Have you tried tape?
No, this is a new thing.
You know, races where
You're
racing, they have tape,
You are our patient.
legs or something in different ways. I didn't realize that that's what was going on, is that they're trying to maybe affect conformation or support.
It could be. There's all different kinds of tape. A lot of times you see the kinesio tape, which is a stretchier tape, and those are kind of like they're probably not going to hold they're not as rigid, but they'll lift the tissue and help kind of facilitate fluid moving out of the joint or the muscles working better. And then there's more rigid tape that you can use to try to shift things a little bit more. Yeah.
Well, that's interesting because is that what you said? I didn't catch the beginning, but I noticed like when I watch people play tennis, sometimes they have like a piece of tape.
They'll have a strip like vertically, and like, what is that doing?
It's just like a piece of tape
or a tape
out in the middle
on their
of nowhere.
arm, like right here.
Yeah, it doesn't go around.
Right.
It doesn't,
Yeah.
That's why, right? It's kind of giving lift or move.
What that tape does mostly is lift, and so. There's all kinds of things that they said that the lift up, inhibit the muscle, facilitate the muscle. I don't know about that personally, but the lifting is really nice, and the lifting can help give space for stuff to get out of there. So it's really awesome if you have a big bruise, put that tape on it, it'll lift, you see the bruise, basically disappear out from under there. So it's just a tool, and it's maybe, I don't know.
Could it
I'm
help
kind of
her?
trying to like,
yeah, I mean, how would I use tape in my situation?
it would depend. It would really depend on what helped you and made it feel better. And sometimes you don't know that until you start playing with it.
So you're just talking about taking a piece of tape and placing it where the pain is?
In this situation, also I've got a video of this particular movement, but this might not be something that helps you specifically.
Yeah.
But once you in this case, let's say twisting it this way made it feel better, and this is the video that I have. And you're going to take the tape and kind of try to maintain that twist. Because it's a more rigid tape.
Yeah.
Or if you were feeling more pain right around here,
Yeah.
and you noticed, so it starts to hurt right here when I bend all the way, and then I'm kind of noticing if I just like shift it a little bit, that feels better, then you could use the tape to basically try to create that shift. It wouldn't be a long piece like this.
To try to hold it in place.
To basically say, okay, I'm gonna give it a little shift with the tape,
Yeah.
and then see, does that still feel better? And if it does, you leave it on, and if it doesn't, it's just a waste of tape. You take it off and throw it away. So, there's lots of little fixes like that would be unique to your knee. But I do at least have a video of that it's called a mulligan move, but he was a PT from Australia.
I bet there's on YouTube. I bet you can find it. You can find anything.
You can find a lot of things. Yes, that's where my video is.
But there's a lot of misinformation.
Yes, that's true.
Yeah.
This is really great for suctioning your kneecap and lifting, and also mobilizing the IT band instead of rolling on it. It's a sink plunger. And then these are a little bit pricey. I don't sell them, but I have a coupon link. Feel that on your, you can even try it on if you want.
My dad had rotator cuff surgery. He got something that was like a little pump, and you put like frozen bottles of water. So it's similar concept to that.
Yes, in terms of it.